My name is Dr. Meghna Ranganathan. I'm a research fellow at the London School of Hygiene and Tropical Medicine, and I've been a member of STRIVE and the Transactional Sex Working Group since 2011. STRIVE is a research consortium that's funded by the Department for International Development to tackle the structural drivers of HIV. The consortium partners in India, Tanzania, South Africa, the USA, and the UK are conducting research into a range of upstream factors of HIV risk, such as insecure livelihoods, unfettered alcohol availability, stigma and discrimination, gender norms, and gender-based violence. Today, Dr. Abigail Hatcher, an Honorary Associate Professor at the School of Public Health at the University of Witwatersrand, will present highlights from her recent work in measuring and addressing partner violence within the cascade of prevention of mother-to-child HIV transmission, or PMTCT. The presentation will be followed by questions and discussions, so feel free to type your questions into the chat box as you think of them, and we will pick them up at the end. Thank you, and over to you, Abby.
Thanks very much. Good morning or good afternoon. It's nice to speak with you all today, and the topic that I'll be discussing is one that I can see many of us have been working on over the years, for those of you whose names I can see on the list. So I'll keep the introduction brief. Many of us already know that transmission of mother-to-child transmission of HIV in South Africa is among the highest globally. And we do have the biomedical treatment required to reduce mother-to-child transmission to virtually zero. And yet, it's very challenging to make this health outcome be achieved in many settings, partly because prevention of mother-to-child transmission takes so many steps. And women during pregnancy and postpartum are required to go through what's been called the cascade of PMTCT. They have to test and they have to take up medicine and they have to adhere to that medicine. So every time they are required to do a new step, more and more women are lost along this cascade. So as many of us know, there are a number of factors that drive poor PMTCT adherence. And these range from personal factors like the burden of taking pills, all the way to household factors such as not having enough food or being very far away from your health facility, all the way to clinic factors. So problems with clinic services or medication not arriving to clinics on time. And so over the last 10 to 20 years, all of these different factors have been considered in a wide range of literature around PMTCT. But one factor that has received considerably less attention in the literature is intimate partner violence. And we'll focus a little bit on what our research in South Africa has shown around intimate partner violence, as well as other research globally. So in South Africa, between 1/4 to 1/3 of women in pregnancy experience intimate partner violence. And this rate is quite high compared to other settings globally, but in fact, it's very similar to other settings in sub-Saharan Africa. You can see from this map that that darker red represents any country that has more than 25% of pregnant women reporting recent intimate partner violence. So just to flag that IPV in pregnancy is a health issue that many women in our clinics are facing. And before our team started this research, there were some links in the literature between intimate partner violence and the steps of the PMTCT cascade. So there were a few papers around partner violence worsening HIV testing, a little bit about adherence to nevirapine. There were several papers that talked about partner violence and worsening prenatal care, and then sort of burgeoning literature around violence and women's ability to breastfeed. So looking back at that graphic, before our team started this research, each of these little steps of the cascade that are starred were ones that had at least some evidence to suggest that partner violence was related to PMTCT. But the literature was rather weak, and so part of what our team did is took a step back and asked, globally, is intimate partner violence related to HIV medication adherence? And so I'm going to go through those findings, and then I'm going to dive in a little bit more to measuring how much partner violence might impact PMTCT. And then the last area of this conversation will be around pathways. How is it that partner violence leads to poor PMTCT adherence? So to understand the global relationship, we conducted a systematic review, and for this, we actually cared about women generally and their ability to uptake and stay engaged in HIV care and treatment. We found 13 studies that examined this relationship, and all of these studies were cross-sectional, and all of them were actually rather recent. We published this review in 2015, and all of the studies were in the 5 years preceding the publication. So if we look at women generally, we were able to find studies only in North America and one study in Haiti. Once we looked at these studies and conducted a meta-analysis, we saw that intimate partner violence is very strongly related to women's ability to stay adherent to HIV medication. Specifically, you can see this in the circled odds ratio. Specifically, intimate partner violence more than halves the odds that women are able to adhere to ART. As we know, self-reported ART adherence may not be the strongest measure of ability to adhere to ART, so we also conducted a meta-analysis of viral suppression and found rather similar odds ratios, not quite as pronounced, but intimate partner violence led to a 36% lower odds that women were able to adhere to HIV medicine. So of those 13 studies that we included, notably, none of them examined pregnant women. So a next step in our own research was to really look at IPV specific to pregnant women, so specific to this PMTCT cascade. And we examined that quantitatively using a trial called Safe and Sound that was conducted in Johannesburg, South Africa. And I'm going to skip over the intervention itself because for this analysis, the intervention participants have actually been removed. But I do want to talk a bit about the setting for this trial. It was in 3 health clinics in urban Johannesburg and conducted among adult women who were pregnant. We made sure that the women did not have an immediate safety risk, so that they were able to participate in the research safely. But anyone who had recent physical or sexual IPV was randomized to either the intervention condition or the control condition. So our sample for the trial was only those women exhibiting recent physical or sexual IPV. What my PhD research did is add on another stream of research to include some women who had no IPV at baseline, but who were living with HIV. So just to take a little bit of a closer look at this diagram, the analysis that we were able to conduct alongside the trial includes control women in the trial itself, which were around 90 women, and then includes another 180 women who had no violence at baseline but were living with HIV. So we looked at a couple of main measures, which we can dive into more in the question and answer if we need to. But the main association was if recent intimate partner violence was associated with self-reported adherence to HIV medication. So we were able to do this analysis with a small group of women, 195, of whom nearly 70% had been diagnosed with HIV in this pregnancy. Just under half experienced recent partner violence, and a strong proportion were adherent in pregnancy and postpartum. But when we looked at adherence by IPV category, those women with IPV had slightly lower levels of mean adherence than those women with no IPV. But any of us who have worked in the HIV field know that these numbers on the screen are not clinically meaningful because often adherence greater than 90% can be considered good coverage for preventing mother-to-child transmission. So while this is statistically significant, it's more clinically meaningful to look at the odds of good adherence, or 90% or more adherence. So when we look at those odds, in unadjusted analyses, women reporting recent IPV have 79% lower odds of having good adherence in the pregnant and postpartum period. And once adjusted for important covariates, in fact, that the odds of adherence worsens even more, and women have 89% lower odds of adhering to HIV medication in pregnancy and postpartum. So going back to that idea of the systematic review, this number, this 89%, aligns with two studies that have been published since the systematic review. In the US, intimate partner violence reduced adherence by 32%, and in Zambia, it reduced adherence by 89% as well. So were we to conduct a new meta-analysis that specifically looked at pregnancy, we could see that intimate partner violence has a robust relationship with women's ability to adhere in pregnancy and postpartum. So here's the part that I think becomes quite interesting. We have this sort of quantitative link between intimate partner violence and PMTCT, but we also wanted to understand qualitatively, why is it that partner violence might be related to women's ability to stay in PMTCT and adhere well? So for this, we conducted qualitative research with 32 women who were living both with partner violence as well as with HIV. And we tried intentionally to oversample women that sort of had challenges with PMTCT because our interest was really around the mechanism. Why is violence and PMTCT related in women's lives? So you can see we spoke to roughly half of the women who were pregnant at the time and another half who were postpartum. And they had been living with HIV for a mean of 2 years. And 62.5% talked about having good adherence. So there were some problems with adherence, but some of the participants actually were able to adhere quite well. So I want to talk through 4 pathways that we found in the data that really related partner violence and PMTCT for these women. The first pathway was partner disclosure. The majority of women spoke about not disclosing to their partner specifically to avoid additional incidents of violence. So Pefe, which is a pseudonym for one of the participants who was 25 years old, said, "My boyfriend doesn't know about this. I just keep it to myself. When I come home to take my treatment here by the clinic, I hide it. Even when I drink my tablets, I would hide them." So Pefe speaks about hiding medication as a strategic way to stay safe while also staying adherent. Other participants spoke about adhering only partially. So they would take meds when they were able to do so safely, but they would leave them at home or avoid the medication when they knew that their partner would be nearby. And importantly, for some who never disclosed, they stopped treatment altogether or refused to start to begin with. The second pathway is really around mental health. And women throughout this small cohort spoke about feeling overwhelmed and loss of hope, mainly because of the partner violence, not necessarily because of the HIV. When there was this sense of overwhelm and this sense that they were feeling very depressed or very anxious about the partner violence, the violence itself would overcome other priorities, like the medication. So Dova spoke about, there was a time when I was really, really down, so I stopped taking my medication. I completely just stopped. And I sort of had this death wish in me that if only this thing would, if it would really work for us, then it would just kill me. I stopped for 3 to 4 months without taking my medication. So Dova sounds like a very extreme case, but in fact, 4 out of the 32 women spoke about stopping HIV treatment as a sort of suicidal tendency. So not attempting suicide directly, but thinking that if they stopped medication, that might allow them to sort of take a break from the violence and the overwhelm. The third pathway is partner control and isolation. And this pathway really speaks to what we all know is part and parcel of intimate partner violence, which is that violent male partners will try to control movement and try to make sure that women can't access the places that they need to access. Kahiso says, sometimes when I go to the clinic, he says, "Hey, you're not going to the clinic." He asks me too many questions, but I refuse. I tell him I can't stop going to this clinic because it's my life. Sometimes when I come back to the house, he beats me. So Kahiso is really speaking about the control that her partner exhibits, but also her own strategies to navigate that and to choose her own health, even if it means placing her safety at risk. Many of the women did use this type of strategic resistance to overcome the many barriers that they faced around the partner violence. And a hopeful fourth pathway was that intimate partner violence is linked to PMTCT partly via motherhood. And motherhood was this real resilient aspect of this time in life. So many of our participants spoke of, I'm doing PMTCT for my baby. I don't want to stress myself so that I leave the tablet. It's better to leave that husband and continue with my tablet. So women spoke about a motivation to stay healthy, a motivation to move forward, that their children themselves were a bit of an antidote to suicidal or anxious thought patterns. And so I think that this is a very important, unexpected theme that we need to harness in future programs. Of course, we can't place too much upon motherhood, but we need to recognize that it can really be a source of hope and strength for many of our patients. So to sum up, these 4 pathways were found in the qualitative research to be important to understanding IPV and PMTCT. So before we stop today, let's take a look at what these mean in the quantitative research. And I want to look at one pathway in particular, mental health, because this is a pathway that we have better measures for. I actually would encourage those of us on the call to think a little bit more about creating strong measures for some of these other pathways around partner disclosure, isolation, and motherhood, because they're equally important, but we didn't have strong enough measures in our quant data to look at those. Using a structural equation model, we were able to look at adherence in pregnancy and adherence postpartum. So just to take a quick look at adherence in pregnancy, we found that intimate partner violence at baseline, which is denoted by this BL, intimate partner violence at baseline was moderately related to trauma and anxiety among women, and these decreased adherence in pregnancy. Importantly, IPV also has a direct link to adherence in pregnancy. So what this visual shows us is that IPV directly worsens adherence in pregnancy, and it also works through mental health to worsen adherence in pregnancy. Taking another look at a structural equation model for adherence postpartum, again, you can see that some of our measures are baseline measures and some are follow-up measures. So intimate partner violence in baseline worsens anxiety, which leads to more anxiety in follow-up. Intimate partner violence also relates to additional cases of IPV postpartum. And similar to what we saw before, there's a direct relationship between intimate partner violence and adherence, plus there's an indirect relationship as intimate partner violence works through anxiety to worsen postpartum adherence. So I want to take a quick look at what this might mean for our programs in PMTCT and antenatal care clinics. The first idea for intervention is to prevent intimate partner violence before it happens, to work with young people and men in particular to shift norms, attitudes, and behaviors, and that will really take away all of these linkages and improve adherence postpartum. The second idea would be to do secondary prevention, and this means stopping the new cases of intimate partner violence. So a woman would enter a clinic at baseline reporting recent IPV, But during the course of antenatal care, she would be assisted by professionals to find strategies to reduce IPV. Alternately, male partners would be engaged in ways that would reduce new incidences of IPV. So that would be secondary prevention, and that would help us sort of stop the linkages in the right portion of the diagram. And then another idea would be tertiary prevention. So what that means is really reducing whatever other health challenges IPV causes. So in this particular model, it would be addressing the mental health outcomes of IPV. And if those anxiety, potentially depression and trauma outcomes were reduced during pregnancy and postpartum, then we could sort of take away those connections at the top of the diagram, thereby increasing adherence. But I have to say, and I'm sure many of you have this experience, in the current very crowded conditions of antenatal clinics, at least here in South Africa, sadly, the likelihood of any of those three intervention strategies is rather limited. I think we all agree that we need to start thinking in that direction, but partly because there has been so little research on IPV and PMTCT, there hasn't been then much attention to creating relevant programs. So I think that would be our challenge going forward. And a very big thank you to the team that helped conduct this research. And as I said, it's coming from my PhD, so a huge thank you to my PhD supervisors, as well as the institutions that we worked with.
I could start off with a question, just because it's a good way to get people to think of others too. So, Abby, thank you again for a very interesting talk. I was actually wondering if do you think that violence, that intimate partner violence and adherence works similarly around the time of pregnancy as perhaps another time in a woman's life?
Yeah, it's a good question because obviously in this presentation we cared about pregnancy, but we were also looking at studies that were just for women generally. And I think that there are some differences that could potentially be harnessed for programs. One would be that motherhood pathway, that this is a time when women are often reflecting around relationships, around their own choices in life. So I think that they could be potentially more receptive to reflecting on the violence and potential strategies for that. I also think there's also a difference when we think about PMTCT adherence during pregnancy versus what happens after the baby's birth, because there is such a strong willingness among many patients to stay very adherent during pregnancy. But once the baby is born, even if they're breastfeeding, it can be difficult to keep up those daily health behaviors because there's just a sense that you're not as connected to the baby and that the likelihood of HIV transmission may be lower. So I think there's something very special around this time that is somehow different from other moments in women's lives.
Mm-hmm. Great. Thank you, Abby, for that. We have a question from the audience from Ms. Daria Pavlova. The question is, did you notice any changes in adherence depending on the level of women's education?
That's a great question, Daria. Thank you. I wanted to look at these notes. Yes. So this is quite small in the bottom, but to understand how these models worked in light of other important characteristics, we controlled for education and food security. And if I remember correctly, the reason we had to control for those two variables in particular is because they were strongly related to adherence. So I could definitely follow up and sort of let you know how strongly education was related. But because we included it in the controls, I'm quite certain it was the lower the education, the lower the rates of adherence.
Thank you, Abby. Another question that I had, just in case, just before somebody else puts a question in the chat box, is what would seem quite obvious, which is that, you mentioned that certain challenges for PMTCT that are addressed by the health sector, like depression and transportation. But if partner violence is such a big challenge for PMTCT, why isn't it being routinely addressed by clinics?
I've been wondering the same thing. I have two suspicions. One is, and I'm guessing a lot of people on this call can corroborate this. One is that clinicians in particular, but programmers all over the world, find intimate partner violence very difficult to think about addressing. And so I think that there's like an avoidance mechanism of clinics not wanting to sort of dive into what they perceive to be as messy and hard to fix problems like IPV, which, is very interesting because, in fact, we do have some proven interventions for intimate partner violence, and in some ways it is addressable. The other reason is, I believe, going just right back to this lack of research. I think until we have enough research and make enough of a kicking up a fuss to show that IPV is a major burden for these patients, then it's unlikely that policy is going to pay attention, and it's unlikely that programmers will design efficacious interventions. So, so partly maybe it's because I am a researcher, but partly I think the first step lies in proving what a huge connection partner violence and PMTCT have for so many women. Well, while others are thinking, just to pick up on a comment that Emmy raised around Strive and the overall purpose of Strive, and as you said, Meghna, one of the foci of Strive is really to think about sustainable development goals and to think about interventions that offer benefits across the sustainable development goals at the same time. And so for me, I think that this idea of secondary prevention of IPV could potentially be very compelling for the health sector, because what you'd end up getting is physical health benefits, because you'd increase adherence, mental health benefits, because you would reduce anxiety and depression associated with IPV, as well as gender normative benefits, because you would be reducing the controlling behaviors and violence in women's lives. So I think through a lens of sustainable development goals, again, this topic might be very compelling. And perhaps blending these various outcomes together would help overcome a little bit of that avoidance that we spoke about at clinics. Perhaps if you could show that there would be very real changes in women's lives across these areas, then you could compel policymakers and programmers to really address this topic.
Actually, related to that, Abby, what are examples of other interventions for this type of IPV adherence link? And are you aware of any sort of economic evaluation that's been done showing how this might be more cost-effective than another intervention that's similar?
That's a nice idea. So I don't believe there are even very many primary studies that simply show a reduction in IPV around the time of pregnancy. So in fact, Magna, what you're pointing to is a crucial next step of we both need to have promising interventions and we need to tie them to economic outcomes or, sort of these cost-benefit analyses. So some of you may know the trial that these data come from, Safe and Sound, was shown to be effective at secondary prevention of IPV. So we're still sort of waiting for the publication of these results, but the trial was shown to reduce new incidences of IPV by 48%, which is quite promising. But that is the first trial of its kind in a low and middle income country, as far as I'm aware. So there are a couple of other very promising approaches in the United States and Canada, as well as Australia. And so those approaches involve training clinicians to address IPV or home visiting around the time of pregnancy, which has actually come up with remarkably strong results. So again, that all focuses on this secondary prevention. I think we need to have more of these interventions tested in sub-Saharan Africa. And then I think your idea of linking them back to economic evaluations could be very promising for the sort of policy arena. Okay, this is an interesting question. Let me read it out. Can you speak more about the missing measurements? What do you think strong measures for motherhood would look like? So let me just go back to the slide where we spoke about measurements. So I think there's got to be something in motherhood around quality of the motherhood experience and something about that tension between the positives and the negatives of motherhood. So I think when we wrote this up originally, a number of reviewers spoke about like over-idealizing motherhood as this magic bullet and this, perfect moment for women to perform so beautifully around their HIV treatment behaviors. And clearly that misses the point completely because there are so many additional challenges and so many additional weights of motherhood. So I think that there needs to be something around the quality and the experience of, say, pregnancy or early infancy, maybe that could capture both the lightness and joy and hope of motherhood, but then also the additional heaviness and responsibility and almost special isolation that motherhood can bring. The other one that I'm actually very keen to see better measures developed for is partner disclosure. It is so challenging quantitatively to analyze how partner disclosure is related to violence and how partner disclosure is related to PMTCT, because so often we ask yes and no questions. Have they disclosed, or when did they disclose? So I think I'm quite interested in thinking about quality of the disclosure experience. So master's student at London School, Elizabeth Smouth, was able to examine partner disclosure in our qualitative data and found out really rich tensions in disclosure, like women felt very anxious before they disclosed, so they'd sometimes go straight home from clinic and force themselves to disclose that very afternoon. So almost as a way to like limit the anxiety and push through, they would just tell their partner. So there's something for me that's a very different quality of disclosure than like a careful conversation that a health provider assists with. And yet on a questionnaire, both of those women would say, yes, I have disclosed. So yeah, I think again, something about quality and nuance would be really, really important. Okay, sorry. So then there's one other interesting question sort of pending on our list, and it's just asking a little bit about how controlling behaviors and intimate partner violence relate. So there's actually a brief on the Strive website that is thinking about measuring intimate partner violence. And just to show you again, we looked at controlling behaviors as separate from intimate partner violence. And partly that was because we cared about IPV as an indication of physical or sexual partner violence. But controlling behaviors is very, very closely linked to intimate partner violence and in some definitions part and parcel of a violent relationship. So I found it quite interesting that controlling behaviors led to more controlling behaviors later. Okay, that makes sense. But they also predicted later partner violence. And again, this makes sense theoretically, but it's really nice to see that the data also represent it that way. And so, I mean, one way to unpack this would be to really look at how women experienced control versus psychological violence versus physical violence versus sexual violence. I didn't do that in these analyses because I think that it's actually quite rich to sort of include all of those definitions together. But again, if people are interested in how you look at intimate partner violence, I think that Magna has, or Sefi has just shared the measurement brief about IPV. Just to say, so if anyone on this call is actually looking more at PMTCT and might be interested in adding IPV questions to an existing study, that measurement brief would be useful. But our team has also developed a short training manual that can be used with health researchers. And this is a way to add in IPV questions safely and also make sure that the researchers are able to conduct the questions ethically, safely, and are supported themselves. So if anyone's interested in that, you can feel free to please email me after the webinar, and I'd be happy to share that with you.
Abby, I have a follow-up question all related to these resources. Have there been dissemination workshops or sort of events around the results of this work? And has there been traction from policymakers at all?
So it's a perfect question because whenever we conduct these kinds of big trials, especially something like Safe and Sound that was the first of its kind in a lower middle income country, the dissemination of the results is imperative. Unfortunately, we have not disseminated outside of one conference presentation. And so it's actually a real concern for me, partly because the women who participated in this research deserve to know what happened, and also because clinics can't get to any of these intervention ideas that we spoke about unless they know what works. So my hope is to push that in the coming months, but the answer is no. There's nothing disseminated yet.
Right. So I guess related to that, what is that considered a next step related to this, or what are next steps for this work?
Yeah, so I think there are two next steps. One is to, as we spoke about, to disseminate the results of the Safe and Sound trial, both in the academic world, but also quite important to us to disseminate it with the Department of Health here in South Africa, to see if there could be traction in terms of incorporating a brief intervention into antenatal clinics more widely. And then the second step is, let me just go back to this slide. Well, here, I can show it just in terms of our numbers. Because we only did the HIV analyses in such a small group, 195 people, and because there are so few studies around this globally, what I would really like to do is sort of take this kind of pilot work to a larger study and really see whether there are ways to intervene in larger numbers with intimate partner violence among those women living with HIV already.
Mm-hmm.
So, Meghna, I have shared my email address, I think, in the chat with anyone on the call. And I believe on the webinar sort of page on the Strive website, there are a couple of open access papers in case people are interested to learn a little bit more about the research part. But it would be excellent to hear from anyone following this, and I'd be happy to share materials that we've developed here in South Africa or for similar studies we've been working on in Kenya.
So thank you, Abby, for an excellent presentation. I'm going to wrap up now just to say that all of our previous Learning Lab presentations are available on the Strive website, along with a series of materials addressing issues and structural drivers. Please do fill out the feedback form, which is at the end of the call, because it provides us with really important information on how to guide these Learning Lab series. Thank you all for your time. Thank you, Abby, for a great presentation, and we hope we can continue this conversation in the future.